thank Dr. GBK for this wonderful opportunity and for the chair for the wonderful introduction. The crux of this topic is this much. We may find pus cells in the urine in many people. Do not keep treating it because it doesn't need treatment. So, this comes because of the lack of understanding of what is called as an asymptomatic bacteriuria. This makes us do recurrent urine analysis, recurrent urine cultures and unnecessary antibiotic usage, landing in many troubles. What is asymptomatic bacteriuria? Asymptomatic urinary tract infection is a bacteria present in urine in the absence of clinical signs or symptom of urinary infection in the host. Microbiologically, they may have a colony count of more than 10 to the power 5 of same organisms or organism in two consecutive urinary specimens, but they will not have signs and symptoms. Uncomplicated urinary tract infection is a symptomatic bladder infection characterized by frequency, urgency, dysuria or suprapubic pain in women with normal genitourinary tract. This is not asymptomatic bacteriuria. Or when complication occurs, including the genitourinary tract, there also it is not asymptomatic bacteriuria. When you see in a normal urine sample as a routine, and please don't start treating it, is the crux of my talk. How common it is? In asymptomatic women, it is quite common compared to asymptomatic men, because in human, unless there are two consecutive samples with the 10 to the power of 5 the thing, you do not call it an asymptomatic bacteriuria. In men, even a single voided urine specimen, a clean catch, that is a mid the thing early in the morning, with isolation of one bacterial species, or in catheterized the thing, a single voided specimen, because it is generally meant to be quite a clean catch. So, in such patients, this is considered to be the thing. If there are no symptoms, that is asymptomatic bacteriuria. So, difference between UTI, again to reiterate, bacteriuria without symptom is just a urinary tract infection or asymptomatic bacteriuria. Bacteriuria plus symptoms is in the thing. What are the symptoms? It could be fever, frequency, urgency, pain are all necessary. At least 3 of the 5 symptoms are necessary to say that the urinary tract symptoms. When you ask for culture, whenever you see pus, you generally ask for culture. If there is a urinary catheter is present and there is a new onset fever, with or without rigors, altered mental status, acute hematuria, cerebrospinal pain or tenderness, increased spasticity, if these are present, then you should look at it differently. These are not asymptomatic basically. So, when catheter has just been removed also this can occur. If any of these symptoms are are there, plus urine urgency, frequency and dysuria is present, then you should send for a culture. If no history of catheterization before 48 hours, in such patients, if the symptoms of fever, urgency, frequency, dysuria and costovertebral pain or the so-called renal angle pain with a suprapubic pain or without it, acute hematuria, these are the places where you look at it with more suspicion as a cause of the fever and this thing. It is quite common, more in older women, it increases with age. When sexual activity, it is more common. Diagnosis of diabetes increases chance. No difference has been observed in pregnant and non-pregnant women. In men, it increases with age, but is less common compared to in women. Prevalence, they say in short-term indwelling catheters, it's around 2 to 7%. In spinal cord injury, it is more than 50%. In hemodialysis, it's around 28%. Elderly in long-term care facilities, it's somewhere around, it's more common in women, that is 25 to 50% versus men, it is 14% and more. Long-term indwelling catheter, almost 100% of people will have a few pus cells, but as long as it is asymptomatic, do not treat it. Commonness microbiologically, Escherichia coli is the most common organism in women. In men, it is coagulase negative streptococci. In long-term urological devices, including catheters, Pseudomonas is the commonest finding. So, question comes whether it is worthwhile treating them or not. You should treat it in pregnant women or if urological interventions are planned. In other people, do not treat this. Even presence of pyuria is not an indication for antimicrobial treatment. You see a chyluric or pyuric, then you start treating it. There's a trigger to treat. Kindly refrain from treating it. In pregnant women, why do you treat it? Usually there's a 20 to 30 fold increase in pyelonephritis in such women, and there's an increase of premature delivery with low birth weight. Urine culture at least once in the early pregnancy must test for cure once treated for and this thing. Treatment, if urine culture is positive, you can give antibiotics in pregnant women. Before urological intervention, single dose of antibiotic needs to be given. No need to overlap and continue till the procedure is over or till they are discharged. Single dose of this thing is given to prevent any infection before this thing. Why I was talking about why this is important is that there's a large non-treatment populations where the risk and benefits have been weighed, and what they have found out is that in premenopausal pregnant women, there has been literally no difference in the cure rate or the presence of this thing by treating. So don't treat. In diabetic women, no difference in rate of symptomatic UTI mortality, number of hospitalization or progression to diabetic complications. So don't treat. Older person in the community, no difference has been seen. Elderly institutional subjects, no difference in the rate of symptomatic UTI, survival or chronic symptoms. Increased rate of adverse drug reaction have only been seen, and resistant organisms develop much faster. Spinal cord injury, as we said, like indwelling catheter as well as spinal cord injury, almost 50 to 100% of them will have this thing, but no difference in the rate of occurrence of bacteriuria with treatment. So don't treat. Long-term catheters, obviously, as I said, don't treat. But when but the risk, do we think that it could be recurrence of asymptomatic UTI, survival rates, hospitalization have not been any different between the thing those who have been recurrently treated and not. So unnecessary urine cultures have been seen in 76% of patients. Inappropriate antibiotic usage has been seen in around 20 to 80% of patients. Increased antibiotic resistance occurs in such people, and increased recurrence rate occurs in such people. So in all these things, do not try to treat it without symptom. And in diabetics, which we commonly seen, there has been clear evidence to say that there has been no real use in giving an antibiotic course of treatment. We've been talking about a month of nitrofurantoin and things like that. Unless it is symptomatic, do not treat. Unless there is an urological placement of some valve or the thing, do not treat for normal people. So why not just treat? You are seeing the thing, patient comes with malaise, we always think that possibly they are going for sepsis. So why not just treat? The problem has been one, adverse drug reaction to antibiotic which has not been worth it. Second is they become multi-drug resistant. So the chance of a real infection occurring when you need to treat, you would have used up all your basic amenities there. And there have been very clear instances where they have treated an asymptomatic bacteriuria or unnecessary antibiotic application where they have become infected with Clostridium difficile. This is a nightmare for physicians. They are multi-drug resistant and the secondary infection which could kill the patient. So the increasing trigger to treat with an antibiotic in people on a community base, diabetics, long-term caregivers, because they will come back with reports to you, keep asking what is happening, but you need to assure them and not other thing. So it is much necessary. So an algorithm which may not always work out is that if fever is there, you ask the first question, is 2 or more symptoms or more than 3 symptoms are there? If it is there, then treat. If not, then don't the thing. You ask for a urine culture, see if anything else is occurring, see if there's a urine urgency, all those other problems, then you should think of treating. If there's a urinary catheter inside, order for a culture, see if it is going significant amount of bacteria, then in some patients you may need to treat. If not, again think in terms of this thing, ask for symptoms again to double check if you need to this thing. If the urine culture grows a significant amount of other thing, if there is a catheter, then you may need to treat it. If it does not grow and this thing, or there is a mixed growth, then do not treat them. So the key point or takeaway is that routine screening for the administration of an asymptomatic bacteriuria is not recommended, both in older individuals, in diabetics, and in elderly residents of this what we call nursing homes. Join the national initiative to decrease and catheter associated urinary tract infections. Good good clean catheterization. You need to keep changing catheterization. So a clean catheterization and use of proper antiseptic to prevent infection should be what we are talking about. Get smart about antibiotics. Do not necessarily prescribe them because you are frightened that the patient made this thing. At least do not precipitate an Clostridium difficile infection because of your trigger to treat somebody. Treat only when symptomatic infection occurs, not in the general public. Thank you.